All right, I'll go ahead and get us started. Hello, everyone. Welcome. Thank you for joining us for our April seminar for the Brown Lifespan Center for Digital Health. My name is Allison Seeley. I'm the project coordinator for educational initiatives at the CDH and will be moderating this session. For those of you who have not joined us before, the Center for Digital Health is a collaboration between Brown University and Lifespan Health System to facilitate the development and dissemination of effective and equitable digital health tools that make a difference in the health of patients and populations. We have a number of strategic initiatives, one of them being to create community and another to educate and build up the digital health workforce. And so as part of those initiatives, we host regular seminars to both expand our skill set and our sense of what's possible and to create or potentiate new collaborations between people both within Brown and Lifespan as well as outside of that. And so as part of that, I'm really excited to welcome Dr. Courtney Lyles to give our talk today on advancing digital health equity from design to implementation. Dr. Lyles is an associate professor in the Division of General Internal Medicine at Zuckerberg San Francisco General Hospital, the Center for Vulnerable Populations, and the Department of Epidemiology and Biostatistics at the University of California, San Francisco. A trained health services researcher, she uses quantitative and qualitative methods to examine quality of care, health behavior, and health outcomes. She is also an associate director of the UCSF Implementation Science Program, which is based in the Department of Epidemiology and Biostatistics. And finally, she holds an affiliate investigator appointment at the Kaiser Permanente Northern California Division of Research. Dr. Lyles' research specifically focuses on harnessing health information technology to improve patient-provider communication for chronic disease self-management to ultimately reduce disparities in health and healthcare outcomes for low-income and racial and ethnic minority populations. She currently is the co-PI of an R01 from the Agency of Healthcare Research and Quality to use machine learning to send personalized text messages to patients to motivate physical activity, leveraging user-centered design and implementation science principles. We're really thrilled to have her joining us today. And so as always, our presentation will last for around 45 minutes and we'll close with about 10 to 15 minutes for some question and answer. So without further ado, welcome Dr. Lyles. I'll let you take it from here.
Thank you so much, Allison. It's great to see everyone. I love questions, so definitely queue them up in the chat or get them ready for the end of the talk. Great. So I'll just go through here and I want to acknowledge up front that, of course, everything I'm presenting today is the work of many, many individuals on our teams. And I have two really close colleagues joining us today, Sarah Lisker and Dr. Adrienne Aguilera. And so I bet they might even be able to chime in on the Q&A if there are questions. So I thought today I would spend a little bit of time talking about the framework for how we've been thinking about digital health equity, just to sort of level set and also potentially provide a framework that might be useful in your own work. And then without giving you whiplash, hopefully go through three separate types of examples of things that we've been working on to show you the spectrum of this work and how to make impact across different projects. And then, like I said, close with a few remarks, but mostly a discussion with all of you. So when I think about health equity, I think many of you may have seen this image before, but I just wanted to put it up here in case you haven't seen it. The differences between equality and equity, and specifically this bottom panel is really where I try to keep my focus, and also where I think technology in particular is really the most important types of adaptations, tailoring, personalization that we can provide. So if we think equity is really meeting people where they are and delivering the right types of interventions and programs to advance health and wellness, then we should be harnessing technology in ways that actually are able to be scaled, personalized, and tailored to each person. To do health equity work, you cannot ignore many different levels driving inequities in our society. And so I wanted to just sort of walk through different levels, give examples of the digital space, and then try to sort of summarize how I think they interact with one another. It's really clear, and I think all of you are aware of, that structural barriers, structural racism, segregation are really at the core of inequities in the US and worldwide. This is just one example of how important structural barriers play out in terms of health and outcomes. These are exits from different exits off a highway in the Central Valley of California, showing actual difference in years of life expectancy based on what exit you live on, and 12-year span, right, in terms of one exit compared to a different exit off the highway. Really big impacts in terms of place and where people live and how their health outcomes look. From a digital standpoint, this gets codified even all the way through the digital environment. These are data right before the pandemic from Pew Research in 2019, showing the percentage of US adults who are dependent upon their smartphone to access the internet. So they have no broadband at home, but are using their smartphone. Oftentimes the data plan on their smartphone, with a limited data plan on their smartphone to access the online services. And of course, this has been emphasized during the pandemic that lower income Americans are more likely to be smartphone dependent. And this is a result of structural situations in our society, right? We have different broadband availability based in different communities. We have different affordability of broadband and devices. And this plays out in this ability for different groups of people to have different access to online services. And it even plays out even further if you think about things like video visits or sophisticated digital health interventions. If you have a limited data plan and your doctor wants to do a video visit with you during the pandemic, you might not want to use your limited data plan or your bandwidth, right, if you're smartphone dependent, to choose to do that kind of service. So it actually has real repercussions that play out in all the types of interventions that we're working on and developing. Another level down are contextual drivers. There's actually a lot of different contextual drivers, but I just wanted to highlight here healthcare and healthcare systems as an important driver of how we think about digital health equity and innovation. This is just an example of different types of healthcare systems. This is hospitals in California and their median operating margins, so their ability to make profit or to be in the red or the black on an annual basis. And you can see here that city and county run healthcare systems, like the healthcare system that I'm primarily based in and do all of my research in, San Francisco Health Network, run at a deficit. And so what this plays out to mean is that if we're implementing digital health interventions in safety net or social service agencies or other institutions, it actually changes the way digital health innovation can be taken up and spread. And frankly, we often are not implementing digital health interventions potentially in these types of settings. We tend to want to implement in other settings and then maybe scale and adapt. And so we've been trying to think about the healthcare systems and the organizational level factors that should be driving the types of projects and implementation that we do. Probably 10 years ago now, almost, we did a study where we interviewed leaders of safety net institutions. And I won't read this whole quote, but just to give you an idea of how that looks when leaders in healthcare institutions, safety net institutions, are trying to think about innovation. This is a quote, let's not be first on the block. We don't need to be. Let some other people die on the sword and learn from that and then do what makes sense for us. And so I see this not as a negative comment, but more as a rational decision to make choices and to have limited priorities, to focus their attention on implementing things that they know have already worked and to generate evidence within these settings directly so that digital health and innovation actually works for them and it can out of the box be something that's ready and able to make impact in these settings. Okay. And then lastly, not going to go through all the levels, of course, there's individual differences in how people think about digital health. I think maybe we spend a lot of time in this domain, potentially in medicine or in clinical interventions. But what's interesting at the individual level, beyond, of course, devices and internet, which I sort of alluded to above, is this need to have the digital skills to be able to use the types of services and products that we're developing. And it's actually a little difficult to get data on digital skills in the United States. We're lucky in San Francisco to have an office or an initiative focused on digital equity. It's housed in our mayor's office of housing and community development. And they were able to do a citywide survey of San Franciscans, I think in 2017 and 2018, to try to actually get citywide data on both lack of home internet and self-reported digital skills on the same survey. And when you put those two together, you can see that people who report having barriers, finding websites, sending emails, doing things that they defined as basic digital skills. If you combine that, the subpopulations of San Franciscans who are non-English speaking or older adults or have lower income have a pretty big barriers to having both internet and skills. And so I just want to make the point here that even in a very tech connected city like San Francisco, adjacent to Silicon Valley, digital skills continue to be something we need to pay attention to and are not a niche part of what we're doing, but actually a core part of both what we design and how we support skill building through public libraries, community organizations, and other domains. One final point about individual levels is I personally do not think interest or motivation is the barrier to be able to use digital health tools. We studied this across a number of studies and in different contexts, and patients are unanimous in their interest in convenience of care, tools that allow them to access more information, to talk to their clinicians. And this sort of underscores this point. This is a national survey again from Rock Health, which is like a digital health incubator, where they happen to oversample in this year what they entitled vulnerable respondents, so lower income individuals or those receiving care on Medicaid. And there's lots of differences, right, on who's using different types of digital, like wearables or trackers and things like that. But the proportions of people who were searching for online health information were pretty identical across all of the groups that they subdivided, and I think underscores this point that there's a lot of interest, there's a lot of need to create better information and better access to health for all Americans. And probably we need to be thinking about designing it or implementing it in different ways if we want to actually tap into that interest. Okay, so that's like a little bit of a whirlwind, but hopefully a helpful level setting of at least how I've been thinking about some of these topics. We wrote something that tried to put those different levels into a single framework. It came out a couple of months ago. It's just using a socio-ecological framework to try to explain and go through these different levels, and then maybe map some different types of recommendations on the sort of lower hand side of this figure of what we need to be doing to advance digital health equity across these levels. And I think what I want to leave you all with is that of course, all of these levels matter, and to push us to working across levels whenever we can, and how important that will be if we want to make movement and really center the individuals that have been left out and marginalized in sort of what we've been designing in a lot of contexts today. Okay, so that's sort of the background. So the first example then, sort of playing that out, okay, great, that's great framework. That's really helpful, but what does that look like in terms of projects or in terms of things that are going on? And so I thought I'd give some examples of how we've tried to take some of those ideas and put them into practice. The first example is a data visualization tool. So sort of it's much up at the highest level, sort of at the neighborhood / policy level. We've been thinking about publicly available social determinants of health data and how to create platforms that might give more people access to these data. So this is a California specific tool, but I think some of the lessons will be relevant for all of you in your own work because a lot of these data are available nationwide. We've created something called the UCSF Health Atlas. It's at this link down here at healthatlas.ucsf.edu. And what it is an interactive data visualization tool of social determinants of health and neighborhood level characteristics. And what you can do on Health Atlas is there's over 150 SDOH variables. You can overlay two variables against one another at different levels of geographic granularity. So county level, zip code levels in some cases, and all the way down to the smallest level that's usually available, which is the census tract level. And so if you see areas of blue, and you can overlay that with areas of a different variable, areas of yellow, and then you can see where those light up on the map, and where there's areas of green, it's where there's both of those variables are co-occurring in a neighborhood or community. We made this resource really thinking about place-based and sort of equity-focused variables. And then, of course, the pandemic hit. And so we actually added a lot of COVID-related information to the website because, of course, we know that place and social risks were intricately linked to how COVID and the pandemic played out. The reason I'm showing this is, of course, I think it's a cool tool. I'm biased, but I'll say that I think the equity approach, or how we conceptualize it, might be interesting, or think a way to that could be replicated, which is we took a framework. We took a framework for social determinants of health from Healthy People 2020. There's, of course, many, many important frameworks and ways of conceptualizing drivers of SUH, but so this is just one example of a framework. And then we tried to find variables that mapped onto these domains, because we really wanted to try to populate as many of these domains as we could in the final platform. So obviously I'm not going to go through all variables, but just to give you an example of like what that means. So for demographics, if that's a domain, we know that California is extremely diverse with respect to race and ethnicity. And so we preserved as much of the granularity in these domains as possible from the US Census data, so that people could actually visualize some smaller groups that actually are often combined or grouped in other ways within the Health Atlas platform, usually representing at least 1% of the California population. For socioeconomic status, just to give you an idea, we included individual like single variables like poverty indicators, as well as composite variables like neighborhood socioeconomic status and the social vulnerability index, so that you can have different views of how SES plays out at a place-based level. Community data has a lot of things like population density and those kinds of things, but also has some custom variables around ethnic enclaves, specifically Asian and Latinx ethnic enclaves. Again, a composite variable about multiple factors of community, like percent foreign born in a census tract, limited English proficiency, and things like that, rolled up into an enclave variable to get a sense of how communities with multiple characteristics might live near one another within a certain neighborhood or area. Neighborhood data includes, I think, some of the more traditional like built and environmental health indicators from different kinds of data sets like the Cal EnviroScreen data. And then lastly, we took out population health level health and healthcare data from national surveys that had small area estimates of some of these domains. So tried to, again, take that SDOH framework and then put it into practice. And then, of course, the target audience for this, we started with researchers in our mind, but I think policymakers, community-based organizations, and others were also top of mind. How can we use this data for advocacy, for other information? And so all of the available came from publicly available sources. It's all sort of integrated here, and then it's completely downloadable and customizable if you wanted to use it in your own work. Not only can you download all of the variables in the data, but you can also custom select your region. So if you're interested in a neighborhood that's 4 different census tracts in San Francisco, you can highlight that and export the data just for those census tracts across all of these variables. So trying to make it available as easily as possible. So that's just one example, sort of at the high level. Of course, I don't think that this data visualization tool is the end all be all in structural inequities or anything to that extent, but I would love, I love the idea of creating tools where we can democratize data as much as we can and consolidate it, but also hopefully use this as a tool to move beyond describing health and healthcare disparities. So hopefully linking information about place in healthcare settings to better individual level screenings and real-time referrals to resources. So can we know if patients report food insecurity, and can we also know about the food environment in their neighborhood? Can we have both sets of information and do a better job connecting patients to resources as they're interested in need? And then at an organizational level, can we use place-based data to actually drive how we deliver services? And the COVID, it was a great example of this as well. I think the blending of public health and clinical approaches to move clinical care like COVID testing and COVID vaccination pop-up sites to the places where it needs to be delivered, rather than having everyone come to us, right, for that type of care. How do we change the way in which we actually do care delivery or public health program delivery using data like these? Okay, so that's at like the top levels, right? Policy / neighborhood kind of level. Now I'm gonna like zoom way down and talk about individuals, right? And okay, so that's like a data visualization tool, very high level, 10,000 foot. what about when you're designing a new app or a new platform for patients or for families in the context of my work, which is at the San Francisco Health Network. And so I thought I would talk for a couple minutes about that, since I'm sure many of you are doing this kind of work. So before I talk about the specific project, I'll say we always are thinking about digital health app or platform design as a co-design process with our patients and families. And so there are lots of practical considerations in doing co-design, like making sure we're compensating people appropriately for transportation and childcare. It's accessible for different types of patients with disabilities. Clearly, language and cultural relevance and representation are core to be able to do this work in San Francisco or in almost everywhere in the United States. And so we think about that a lot. And I'll talk about language in particular in the study that we're doing. And then we also think about the methods that we're using, the power dynamics of how we're collecting data, how we're empowering people to participate in the methods, and then designing in multiple different contexts. So I just showed you data about devices and connectivity. And so we really try to make sure if patients are more likely to be Android users, or we have some iPhone and Android users doing it in both platforms, making sure we're designing on older versions of the Android platform, making sure we have designing on the actual devices and connectivity status that exist amongst our patient population. And then, of course, there's clear principles that drive this work, like honoring the lived experiences of our patients, having long-term view of partnering with them rather than a transactional sort of project by project view, and then trying to do this work to build trust and have community building as a part of what we do, not just to generate a really great digital health platform. So that's sort of like how we start the work. The one project I thought I would talk about today is done in collaboration with my co-PI, Dr. Aguilera, which is called Diamante. And this study is a R01, so it's like an example of a federally funded R01 research project where we were designing a new text messaging platform to encourage physical activity for patients who had both depression and diabetes, because we know that physical activity is important for both of those conditions and that they co-occur at really high rates. And to meet the needs of our patients at San Francisco General, we doing this in both English and in Spanish simultaneously. This is our amazing study team down below. So like I mentioned, of course, at the beginning, the equity view of what we have here is really to be able to tailor things based on individuals. And yet a lot of the apps that we have available in the App Store are only still available in English. That's like one domain. And yet we are not able always to leverage the power of technology to do this. And so Diamante by design, of course, was doing this for both English and Spanish simultaneously, and trying to be clear that the product would work in both languages and for both groups. I'll focus a little bit more on the design part today, because since the RCT is still ongoing. But essentially, we had a 5-year project funded by ARC, but we tried to spend as much time in the design phase to make sure that what we were building was the most useful and relevant as possible. So we did about 3 rounds of design work with our different patients in our system, from open-ended to more closed-ended, like giving us feedback, to generation of text messaging content and practicing using of the text messaging platform to just sort of make sure from the beginning to the end that it made sense and that we could continue to improve it as we went along. I don't have time to go through all of the different changes of what this co-design looks like, but just so many changes and improvements made to the final platform based on this process. Of course, we changed the way that the platform was delivering. So what messages said and sort of how often they came, and whether or not it was one-way or two-way texting. But some of the other important changes that we made were related to the high rates of chronic pain in our patient population and disability, and making sure that their goals for physical activity made sense and were relevant for them, given their other chronic conditions or their other things happening in their life. So allowing people to set their own physical activity goals in the study came up as an important part. And so we were able to adjust that and reflect based on what they wanted to work on with their physical activity goals. I want to make one comment about the methods part of this design process. We wrote another paper trying to tease apart how participants engaged specifically in those generative type of design methods, like um, generating new text messaging content or brainstorming sessions. And I just wanted to put it here because I think it's important to combine different methods across the design phases and to make sure you keep an eye on how you're thinking about co-design. We had thought about patients with communication barriers, potentially like patients with limited English proficiency, health literacy, or digital literacy skills, and just trying to think about how they participated in our methods and whether or not we were doing an okay job getting their feedback on our platforms and tools. And here you can see there's differences across these groups and the importance, I would say, of combining methods by doing generative methods, by also combining observations of patients using the technology, and how important it is to do multiple types of methods to make sure that you're getting input on what you're designing and that it's working appropriately. Okay, I'm sure you're wondering what we ended up with, so I'll just be brief here, but so we ended up creating something from the patient perspective, hopefully is very simple. So it's an app on the left-hand side that they download onto their smartphone, but they don't actually have to open or enter anything into the app. It's the way to collect their pedometer step count on their smartphone. And so that's running in the background and they can look at it if they're interested in seeing their trends. But really, patients are interacting with the intervention on the right-hand side, which is just in the most active intervention arm, 2 text messages per day, one about feedback on their physical activity and one in a motivational category of motivating them or giving them more advice and tips about doing physical activity. And so we knew that our patients own smartphones, but didn't necessarily use apps as much based on all of our design work. And so we have an app on the phone, but really all they really need to do to participate in the study is to receive the text messages and to carry their phone along with them. So that's sort of how it operates. On the back end, there's a lot more fancy algorithms and things going on. We partner with a lot of computer scientists and others to actually try to personalize the text messages and to try to send the feedback message and the motivation message and the time of day of when these messages were coming, to use a reinforcement learning algorithm that took into account who the participant is, like their language, obviously that they're participating in the study, and their gender and their age, and also the time varying information about that participant, like what messages have we sent them in the last week, how many steps have they had in the last week, so that the algorithm can try to predict and upweight messages that might have the highest probability of more steps tomorrow. So I sent this person a family focused motivation message with feedback, right? 3 days ago. The algorithm knows how many steps that person did on that day and then can upweight that type of message in the future so that the participants get more messages that are most predictive of step increases as time goes on in the study. This is essentially how it's working. And that's, happy to answer questions about that, but essentially wanting to use that tailoring and that personalization piece that I mentioned earlier and put it into practice, but not have the participants feel overwhelmed by any of this algorithm on the front end. They just receive the messages. Okay, so at this, like zooming down into this patient level digital health design, I would say the kinds of things that I would take away from this work and other work that we do in this space is that even in academically oriented digital health research, I think it can feel a little bit rigid, or it has to be done in a certain way to get an NIH grant or the types of places that we might be seeking funding from. But I think what I would love to emphasize is that you can blend co-design approaches with more traditional evaluation, like RCTs and other things. You can build in time in your projects and do this in a way. I wish it was even more funding to do it in more languages and to spend even more time doing some of the stuff that I know takes more money and more time. But I think trying to be thoughtful about how to do this work and how to make the timelines work to be able to do the types of things that I think are centering the end users and really starting from the place of whether or not it will work for them. Of course, I think the design example, hopefully thinking about the methods and matching the methods to the end users, also the idea that different methods are going to be get different information, and we have to keep a careful eye on equity within our methods and making sure our measures and our methods are actually getting out of them what we're trying to put out in the world is getting back information that's the most useful. And then I haven't shared, is this intervention effective and how did it roll out? A lot to come on that in the future. Of course, we rolled out Diamante in the midst of the pandemic, which we've learned a ton about, and I just didn't have time to talk about today in terms of physical activity during the pandemic, especially for mental health and chronic disease management being two really important things to think about, given the last 2 years of the world. Okay, so that was like a really high level example and then a really zoomed in example. And then the last thing I thought might be interesting for you all to hear about is like kind of blowing up this model. So I think most of you are in an academic setting or healthcare setting, and we tend to know our audiences really well and think about that. But over and over again, in my work at least, I started to realize that my expertise clearly is not in scaling something like Diamante to be available for many, many people. I don't have a business background. I don't necessarily know how to do those things, but the private sector clearly needs a lot more thought about measurement, all the things I just talked about, measurement, evaluation, equity, and I did have a lot to offer in that domain. And so my colleague, Dr. Urmimala Sarkar, and I started to think through like academic industry partnerships and how can we put equity into this mix. And in the backdrop of this, we were talking to a lot of people. So we were doing a lot of meetings. We ended up doing a study where we interviewed different people across, I would call this the digital health ecosystem. So the different colors in this little radar chart are healthcare providers and clinicians, a population that I feel like we had spent a lot of time thinking about, payers as the next level up, vendors, which is really digital health companies, people developing, entrepreneurs, people developing products in the private space, and then venture capitalists in the orange. And what kept coming up over and over again was everyone was really committed to health, right? And actually had a mission to advance health for the populations. But when it came down to immediate priorities, you can see that the green and the orange lines for companies and venture capitalists tended to be much more focused on outer settings. So business models, reimbursement, regulatory payment, those kinds of things as immediate priorities that they needed to solve to make their product viable in the market. And when we interviewed healthcare providers and payers, they tended to emphasize the inner setting, which tended to be more about workflows, implementation, EHR integration, things that were impeding the progress of digital health tools from their viewpoint. And this is to say, we kept coming across this problem of it was almost like we needed to set a shared agenda for what to work on in this space and to talk together about doing this, because otherwise our arrows clearly might be pointing in different directions. And so we decided to sort of formalize public-private partnerships in something we call UCSF Solve Health Tech. Really to try to take our academic knowledge, like I mentioned, and to try to do some level setting and to communication and convening with digital health companies. And so, and because we're health equity researchers and we're based in a public healthcare delivery system, that's central to what we do. So from the outset, we were going to focus on digital health equity, but we were going to reach out across into private companies and try to think about what is the useful use cases that we could provide in this market. And so we formalized this in 2019, added additional leaders to our team like Adrian and Sarah, who's here today, who helps us lead this work on the day-to-day basis and try to formalize and standardize this work. What we did was in 2019, we actually said, okay, well, which companies want to work on digital health equity or want to work on the types of things that we know about? So we held a pitch competition for companies. 33 companies applied, and we had an industry panel, a judging panel, who helped us select 2 winners from that competition process. And we added a 3rd company that we started working with in this initial incubation cycle. We can't go through all of the deep work with each of the companies today, but to give you an example of like what that looks like, one of the companies that we partnered with within our inaugural incubation cycle is called Inquisit Health. They had already developed a remote peer-to-peer mentoring program they had a specific version focused on patients with diabetes, and they had already implemented this program in a more safety net focused healthcare system, Montefiore in New York. And so this specific project came about to be about evaluation. Could we partner, truly partner, and share data with both Inquisit Health, the company, and Montefiore, the healthcare system, and try to evaluate the rollout of this product with an eye towards equity and with an eye towards implementation? And so we worked on this over that first 18-month cycle and published a paper all together on this topic. The thing I could say a lot about the findings, but I think the things that what we were laser focused on was sort of on the left-hand side of how was the uptake and the rollout of this platform received, and whether or not the patients with diabetes who use this Inquisit Health platform looked like the rest of the patient population at Montefiore. So of course, the first bullet on the right-hand side is like effectiveness. Did A1C improve? Did they improve diabetes outcomes? But from the beginning, we were laser focused on, yes, that's great, but who improved the diabetes outcomes? Did they look similar to everybody else? How did the mentors and the patients match up in terms of race and language and diabetes treatment, like insulin versus non-insulin? Were they doing a good job with matching? How often were they able to communicate with one another? And then, of course, central to what we're interested in, can we report out the number of times that the coaching happened via phone call versus using the app? Like, how digitally enabled was this coaching within the program, and how can we advance the digital components of it? And so hopefully you can read the paper more, but just to give you a sense of, the company had already thought about A1C, but I think the other outcomes that I just mentioned were newer ideas and outcomes that are for them to pull out of their data and to report out on, that show both how well they did and potentially areas for improvement moving forward to actually make true impact among the patient population that they were trying to reach with their platform. So that's like one example. I think these partnerships, this deep work with companies, have a lot of opportunities and a lot of lessons learned. The first is that there were a lot of companies wanting to think about equity. And I think from our view, we were able to continue to center equity from the outset in types of the partnerships that we wanted to work on together. And so that's been great. I think it's even grown over the past few years. I would say the companies have taught us a lot about return on investment, ROI, and business cases, and how we can help build a business case with them for how to address diverse patient needs and the immediate priorities that we see as essential to advancing equity within the space. We kept coming across this need for increased communication and shared agenda setting, which I'll talk about in a second, which continues to be a focus of Solve. And of course, I think you can still do this work and focus on implementation, right? It's great to have shiny digital health tools. I love them in some ways, but in the same time, it has to work in settings like San Francisco General, where I'm based, because that's the really important implementation and contextual space that I talked about earlier. And so we've been able to emphasize that in all these projects as well. And so hopefully these are helpful to move us forward and to think about new company partnerships and new relationships that we'll expand as Solve continues to grow. The communication and convening function I just wanted to end on, it continues to be such an important part of what we've uncovered with Solve Health Tech, because when I showed those different alignment of priorities between different groups, I think some of the first steps then are getting us together in the same room, talking about the real issues, and then having different stakeholder groups be able to state really explicitly what their equity goals are within this space and what they need to see happen. And so we were able to have a summit last year in 2021 with such excellent keynote and other speakers like Dr. Nunez-Smith and Dr. DeSalvo and Dr. Tuxen as examples here, and just learn from each other, both in the private sector, the government sector, and other sectors, about what really is the agenda that we're trying to set forward with respect to digital health equity, and what is the role of private companies and VC investment to be able to make movement on this. And so I think this is more of an ongoing thing is what has emerged, but I just want to put it out there that when you exit your academic silo and want to work across with other stakeholder groups, that you have to be open to actually level setting with those groups to get this conversation going. I see so much potential to do demonstration projects or to be even more deeply involved. But the starting place was actually having us all talk together and how important that might seem. It seems kind of basic, but I just wanted to emphasize how important it truly is to advance equity within these domains. Okay. I see like a couple mini comments. I'm glad we have almost 15 minutes left to chat. So to end, I just wanted to say, I don't have much to say. I just wanted to say, essentially, I hope the framework and sort of the multi-level view that we talked about at the beginning resonates with you in your own work, and that you probably already are and will continue to think about multi-level and interconnected ways of thinking about digital health equity and working across the levels. In projects. I don't think all of us can work across all 5 levels all the time. I'm not trying to be, it's overly ambitious, but how can we push ourselves to do something differently and out of our comfort zone that maybe we weren't doing before? I think we have so many decades of public health and other expertise in health equity and other domains like theories, frameworks, knowledge. How can we take those and put them into concrete practice in terms of data science like Health Atlas, or in terms of relationships with or communication with private sector partners? How can we take some of what we've known in the 2 worlds of digital health and in health equity and sort of bring them together and put them into practice? And then I think the stakeholder engagement piece has to be both broad and deep. So starting with examples like Diamante, really starting from the place of patients and communities and what's needed and what they're interested in, and really staying really laser focused on that, making sure we move up through implementation in settings that serve the populations that have been marginalized and excluded from a lot of our digital health work and other instances. So really important to me is to implement in the types of settings that treat and are working with patients and families and communities. And then I would say the broad part is maybe public-private partnerships. And hopefully I've convinced you that going broad can potentially increase our impact in this space. And how can we do this better moving forward? I think that's all I had into this beautiful mural that is in our offices from Perceived to Eyes. And I would love to stop sharing so I can see all of you and look through the Q&A.
Thank you so much for that great talk and for the insight that you have provided from the framework of thinking all the way through to how we build partnerships with people we may not have considered partnerships with previously. I saw several chats come in, a couple focused more around Diamante and other more about the framework. So I'll invite folks now. Feel free to chat your questions or raise your virtual hands, and we'll call on you as best we can in the order that we saw them. So Adam, I noticed you chatted a couple of questions around Diamante. Would you like to share those, unmute yourself and share those questions?
Sure, thanks so much. I did residency at UCSF. It feels like a lifetime ago, but I'm always impressed by how ahead you are in the digital health realm. I'm curious because the Diamante intervention is incredibly impressive. It also seems incredibly expensive. And I was wondering how you kind of transition from nothing to that, whether you had institutional support, foundational, or got NIH funding to make the first iteration.
Yeah. I don't think it was super expensive, I guess. That's how I would, my short answer. The long answer is it's funded through a single R01 from ARC, which is ARC actually doesn't have the highest of budgets. So it's not a particularly expensive project from a federally funded standpoint. It is a 5-year R01, so it's not like nothing. The algorithm itself was able to be starting from a place that another computer scientist at Microsoft Research had developed, mostly for existing employees at Microsoft Research and a few other small pilot projects. So we were able to start with some of the algorithm from an existing place and adapt and extend it. So we didn't have to start from scratch with the reinforcement learning algorithm piece. So that helped us move faster. And then the design work, was a specific aim within our R01. So we built that in and we worked on that and spent probably over 2 years working on that. And so we tried to resource that appropriately within our budget because of how how important it was. And I think that was the point I was trying to make. It's not always easy to convince reviewers that the length of time is needed and all of those things, but I think we tried to make the case of the science involved in that design work, and we published a lot of scientific papers that came out of the design process. And so that was one aim, and then we resourced that appropriately. I mean, you can do things relative, small numbers of patients and multiple iterations. We're a very shoestring kind of place. So we pulled it all in terms of that. We pulled it all together and continued to move on it. And so I'm glad you think it seems expensive, but it's probably not overly, budgeted, and no other foundations or anything else have supported. Dr. Adrian Aguilera, who's here, I mean, I think has been able to, he's had a text messaging platform through other studies, and things like that, healthy SMS. But it's, it's really, we didn't start from nothing. Don't get me wrong, but I don't think it was super as maybe advanced. All of you could do it, I think, is what I'm trying to communicate. If you and happy to chat about how to budget things or how to do things. I think that's really where the rubber meets the road to be able to do this. It seems like, how could you find enough money to do it, and how do we squeeze it out to try to make it possible? Is my honest answer.
Thank you.
Yeah.
All right, I'm going to pass it over to Kim Gans. I saw you had 2 questions in the chat. Would you like to share those with the group?
Sure. So if I can remember. So the first question had to do with best ways or how you measure health literacy and digital literacy. And then the second question had to do with the Diamante intervention or just interventions in general. And if you considered tailoring on like neighborhood environment or built environment characteristics related to like neighborhood safety or walkability or anything along those lines, if you have considered building that stuff into your messaging platforms or anything like that. So those are my 2 questions.
Great questions. For health literacy, there's a lot of different measures. We have used a single item measure for health literacy about confidence in filling out medical forms and navigating the healthcare system on your own, which is, I'm happy to send the reference. We validated that in English and Spanish. So that's what we use for health literacy. For digital literacy, actually in that paper, we actually had to define it ourselves, but it was self-reported ability to do sort of tasks like sending text messages on your own, using your phone on your own. And so I can't remember exactly which items we use, but it's in the paper that's linked in the slide that I'm happy to share with everybody, because I think we actually have a lot of work to do methodologically to have a standard definition of digital literacy. And we're trying to work actually on a small validation study on that specific question. So if anybody's interested in that, definitely reach out to me, because there's lots of domains, right? Do you have the devices and the data, like I mentioned? Is it skills, right? Like which piece of that? And if it's just skills, what are the skills that are considered, needed, especially for a healthcare intervention? The one thing I'll add on that is that the Office of Digital Equity in San Francisco used those 5 tasks to define basic digital literacy, which it's a pretty good starting place, like able to find a website, send an email, fill out a form online. I can't remember the other 2. And the person had to sort of report, yes, no, I can do all of these tasks. And so they sort of came up with a basic measure, but I haven't seen a gold standard that, I've been asked this question a lot in the last 2 years in particular, and I wish I had a study. So if any of you are working on it, you let me know. And then in terms of Diamante and the structural pieces of Diamante, like walkability, safety of neighborhoods, things like that, we did actually think about that quite a bit. We decided that 3 different algorithms running for motivation and feedback and time of day was probably as complicated as we could actually implement within this R01. And so we didn't quite go down the path. We do have measures of that on our baseline survey. So we'll be able to look at that as a mediator of our intervention. And then we've also, which I didn't mention, we've also asked people to additionally track place. So the geospatial, like actually the GPS on their Diamante app, if they were interested in providing those data to us, a certain proportion, a relatively large proportion of patients agreed to give us some spatial information about their walking. And so we have a lot of desire to look at those. We haven't peeked at them yet, but look at some of those data, because we're really curious about where people lived. Were they near parks? Were they near certain area? What else could we do in this intervention? So it's definitely been in our mind, but we haven't quite fleshed it out. And so would welcome collaborations or thoughts on those pieces that we haven't quite gotten to. Yeah.
Great, thank you.
Yeah.
All right, Jedri, you had posed a question in the chat. Would you like to share your question with the group?
Hey, hello. Sure. So my question was, thank you for sharing the socio-ecological model earlier. I was reading about Larry Keeley. He's always saying that we're always designing anything within a system. And he has these 5 E's that he says that should be considered for customer journey, like the customer journey. So the 5 E's are entice, enter, engage, exit, and extend. So I'm working on this artificial caregiver, and I worry about the temporal context that this might have on, on the equity of it all. In your research, is the temporal sequence that you're looking at mostly at barriers at the levels of the socio-ecological model that you presented earlier?
So do you mean, when you mean temporal, just so I understand, do you mean like thinking about policy at the same time as individual, like, or are you thinking working on policy first? I guess I'm trying to understand the temporal part specifically
I'm just
about what you're getting at.
I'll be right. Is this your office? Okay. I'm sorry, hello?
Yeah, I was just curious, what do you mean by temporal? Do you mean like working across the levels at exactly the same time? Or is there a level first that's most important to work on and then you sort of step out?
I'm coming at it from like a product design context.
Yeah.
Like enter, entice, extend,
yeah,
that kind of thing.
I think my best advice for it is from a product design standpoint is just to, in the discovery phase or in when you're actually building something and in that co-design work and you're really thinking about it, is to not be too narrow about how you're collecting data from individuals. You're never going to solve for, it is impossible to design one thing that is perfectly tailored for one group, in my view. However, if you are ensuring you have a diverse group and you're ensuring that you have like almost principles. So is language on the table, is digital literacy and devices, different devices that people use on the table. Like what are the features that I'm gonna, and then can I select end users in that early phase that will give me input on how to use this with an Android that's 5 years old and how, right? And how to do this with, I don't know, I'm trying to think of other parameters. I think being explicit about the parameters up front is most important because you end up getting, like, for example, for caregivers is a great one, right? That's at the social level. You're automatically involving another person in theory, right, around this. And so what is the dyad going to be? Are both of them going to participate, or are you only working on the caregiver? Those kind of things. The more I think about it, yeah, it's more of like just keeping that in your brain and then trying to be explicit about how you operationalize that. You might not be able to get broadband into the home of everybody for your specific study, but can you make sure you're asking questions about how they're accessing internet at home? And can you make sure at least you're working on, some other domains in terms of like accessibility, like different versions of the technology and language and or caregiver, like just trying to be explicit about it is what my advice is. I know that's kind of practical, but I think that's the way I think about it. I think what I often see is just, well, I can control just this one domain, or I can, you know what I mean? I have the ability in my study to do one thing. And in reality, you actually do have the ability to broaden out. There's some people who are going to be coming at it from the policy angle and some people who are more oriented at the individual level, but how can we actually think about going across a little bit more? And sometimes it's data collection or who you're recruiting or the methods that you're using that's going to get you more information than your initial plan.
Okay. Thank you.
Yeah, no problem.
So I think we have time for maybe 2 more questions. Feel free to raise your hand or chat your questions.
It's just scrolling through the chat. I'd be happy to answer any more about this.
I have a question. Thank you so much. So I have been finding this gap, like you mentioned, growing larger and larger in the sense that, okay, we need this product, but the person who needs it won't be able to pay for it. So investors are not interested in funding.
Yeah.
So what would you advise the solution for this be? How could the industry academic partnership take this ahead? Or if an individual wants to go ahead and build something, what do you suggest the best way to move forward would be?
Yeah, I think you're exactly what I was feeling, and how we were founding Solve Health Tech was a lot of the business models that I heard about, or that companies came and talked to us about, were getting advice from who their investors were, that they had to do commercially insured patients first and then pivot to Medicaid, or just messages like that. And I think what I have learned from doing this progress is, of course, the ROI, when you think about products that are going to work on social needs or other things, is potentially more complicated. However, I would say that the Medicaid market is not a niche market. I think that what I want to leave you all with is, like, there is a business case here. It's not a niche market. It's not a small population. And I think the more we talk across academics into the private sector about how many patients have these types of barriers, how many of them are interested in wanting solutions, I think we can actually help drive that, because I actually think there's some myths out there in the private space about how to invest and how to do this. So that's what I'll say about that. That being said, on the flip side, the companies that are founded by entrepreneurs of color or people with lived experience or other things have structural barriers set up against them to be invested in and actually have some of the solutions. So we both need top-down ways to invest in private solutions that are gonna actually elevate the solutions that are more likely to be doing what you're doing. And I would say at the same time, knowledge about evaluation and ROI that you have to actually, and I think that's where academics are good at, the nerdy stuff, right? What is the cost effectiveness model for this? We can prove a lot of that. And we haven't quite been thinking about it in the ROI way, but there's a lot of evidence. Like in California alone, Medicaid is 1/3 of all Californians, and 1/2 of all births in California are on Medicaid. It is not a small proportion of the California population. And yet it's sometimes talked about like, oh, we'll do that next. And so that's like, it's a pretty fundamental message, but one that seems to be clear that not only do I know about that, but I think the companies and engaging with VCs is needed, right? They need to hear that message. They need to have communication that can help them articulate that. And then maybe we can change how it's invested and how it's thought of. But I do agree that's a problem, but I think it's maybe a somewhat made up problem. Like we need, it's not completely made up. Of course, you need to make a business model that's viable. However, I think sometimes we put up these ideas in place and we haven't actually executed on the type of business model that I think is possible in this space. And I'm really excited that people are more interested in talking about it, but I think we need real action. Different investment.
I totally agree. In fact, if federal companies and agencies and healthcare start investing and taking equity, it will actually help them in the long run. So that would be a good idea.
Amazing. Yeah. This has been really fun. Thank you so much, Allison.
Yeah, thank you all so much for your questions. I'm chatting a link to help us continue to improve these seminars moving forward, but just want to say thank you so much to Dr. Lyles for this great conversation, and to our audience members for asking such good questions. And then of course to Sarah for chatting us all those links to the studies. Appreciate you all so much. Our next CDH seminar is going to be in May, on May 25th, with Dr. Bobby Wagner, who will be discussing her startup Groups, which is an emotional wellness platform that reinvents the group counseling model. So feel free to register at the link provided in the chat. We hope to see you next time. Again, thank you to our guests for today, and we'll see you next time.
Thank you.